Good afternoon, everybody. It's great to have you here. Thank you for joining the third webinar in the Kootenay Boundary Division's Future of Clinics webinar series. Our focus today will be community health centers and exploring business and governance models. Before we go any further, I'd like to very briefly just introduce our team here at Kootenay Boundary Divisions. For those of you who may not know all of us, I'm Kate Mahoney, and I'm a project manager working on the engagement process to explore the future of clinics in our area with Andrew Earnshaw. He is our executive director. Hi, Andrew. We also have Leah Jackson, who is our behind the scenes wizard, who's helping us with all the technical details of everything and is an administrative coordinator. We also have several Kootenay Boundary Divisions board members with us who are also members of our advisory group to help us and guide us with the Future of Clinics initiative. So I'd like to welcome Dr. Ellen Smart, who's a physician in Castlegar. We also have Janet Morton, who is our community representative in our area. And we have Lori Varigan, who's a nurse practitioner working in Trail. So thanks all of you for your constant support and engagement. I just want to very briefly go over Zoom. I know we're all working with Zoom on a regular basis now. So just a brief reminder, on Zoom today, we have both chat and a Q&A section. So if you have any practical questions, logistical issues, difficulties, please just type them into the chat and Leah will be there to help sort them out. As we go through the course of our presentations today, if you have any questions that you'd like to pose to the panelists, please type them into the question and answer function. We'll be reviewing those, and the second half of the webinar today will be focused on Q&A drawn from those questions. You can also do a little thumbs up if somebody else asks a question that you would like to vote for, that shows that you feel it's an important question too. Towards the end of the webinar, hopefully we can open it up for direct verbal questions, in which case you can raise your hand. So if you see at the bottom, there's a little raise hand icon. Okay, with that, I'd like to hand the floor over to Dr. Ellen Smart, who will give us a bit of an overview in terms of where we are in this process of exploring the future of clinics.
So welcome everyone to the third of 3 webinars exploring the concept of community health care centers. So for those of you who have attended the last 2, hopefully today will just deepen your understanding of what can exist in a community healthcare model. For those attending for the first time, welcome. And these webinars are part of the Kootenay Boundary Division's engagement process to explore what the appetite is in our region to open a network of community healthcare centers and also to learn from the folks who are involved directly with community health centers as practitioners, managers, advocates in other areas. So the purpose of these webinars is, again, to facilitate learning and discussion on the different aspects of making a transition to and operating a community health center. I think I'm just going to say CHC. There we go. So each webinar is an opportunity to hear directly from these experts and to be able to ask them questions. So today, as Kate said, we're going to focus on community CHCs, but particularly the business and governance models. And for physicians thinking about making a shift from private practice to a CHC, you know, I guess the joke is always the devil's in the details. And today won't be an exhaustive description of business and governance models, but it should give us a start in thinking about that process with the people that are here to give us their perspective. So I hope you find it interesting. And I think that's all I've got, Kate.
Thanks so much, Ellen. So our agenda for today is We've got this bit of welcome and overview, and then we have really sort of a structured dialogue with panelists. So I'll be asking them some questions to hear more about sort of the different ways in which their CHCs are structured in terms of business and governance models. As we go along, if you have any questions, please do just type them into the Q&A box, and then we'll kind of shift to the second part of the webinar will be focused on taking those questions that you've submitted and asking the panelists to respond to them. With no further ado, I'd like to really look at the speakers that we have today. We have Christine Matuszewska, who's been very involved in supporting Team Excellence with Patient Society, or STEPS. They have just recently opened up the Orchard Walk Medical Clinic in Kamloops. Christine brings quite a business background and acumen to her current role as the Executive Director for STEPS Community Health Center. And she's also the treasurer for the BC Association of Community Health. Grace Schauler, who's an RN, is currently serving as the BC President, Association of Community Health Centers, and he's also worked in the past, he's also on the transition team for Island Sexual Health in Victoria. He previously worked with the Kool-Aid community in Victoria. So he has quite a range, quite a multifaceted perspective on community health centers and team-based care. I think he mentioned to me that his CHC is currently in the process of making a shift in terms of what their business model is, so it'll be interesting to hear from him on that. And Laura Bantock, RN, is the Executive Director of the Sun Peaks Health Center. So she provides nursing support at the clinic, is the Executive Director of the clinic, and is also on the board of the BC Association of Community Health Centers. So she can provide that kind of administrative as well as clinical perspective in terms of how they're working there in the Sun Peaks Health Center. Dr. Chip Bannock is also at the Sun Peaks Center. He's been a family physician for 30 years in Ashcroft and then to Kamloops, and has also been very involved in the Thompson River Division of Family Practice. He's very involved with the clinic now, so he can really share with us that physician perspective on what it feels like for a physician perspective working in a community health center. Okay, so with that, I'd like to dive in and ask a couple of questions. The first question I have is really for Christine. So Christine, as we mentioned, you've really been in the thick of exploring different business and governance models in your work to establish STEPS and the Orchard Walk Clinic. So we'd really like to hear from you in terms of what is your current business and governance model, and sort of why is that approach working for you? And maybe what are some of the challenges?
Sure. So supporting Team Excellence with Patient Society was brought together by Dr. Selena Laurie, and it really was a response to having a lack of family physicians in the Thompson region. And it was really built on lots of work done by the Thompson Region Division of Family Practice. So it was kind of the perfect timing. We had 3 IMGs who were interested in working together, and we had the perfect opportunity to set up Orchards Walk Medical Clinic with them starting. So we had a board of directors. Dr. Selena Laurie recruited the directors, and they created bylaws. Part of that structure, and it's not-for-profit societies structure that they chose. And they did that because they wanted the ability and the option to possibly have members in the future. They wanted the ability to consider charitable status and different funding sources. And they also wanted the direction of community with that community not paid volunteer board of directors. So our composition of our board includes having an accountant or lawyer, an Indigenous representative, a fundraising specialist, and 2 registered healthcare professionals, and then 2 other people who have needed skills at that time. So that's the composition. That's where we've landed on as far as a business structure. What we kind of have played with and we talk about kind of moving forward are how do we support our community? And we've looked at possibly partnering with a co-ops type structure with other providers who are interested in having our support and partnering and identifying synergies. We've talked about possible partnerships, so our society partnering with private family practices. And we're kind of in the, we're on we continue to grow. So over the last 2 months, we've had 4 different family doctors join us. I actually have an email from one of our doctors, Dr. Tracy Smiley, and I'd just like to share it with you all. So she said, "Hi, Christine, you can let the physicians know that I'm very happy with my move from private practice to STEPS. I think the key to physician happiness is having the right group of people working together with similar goals and philosophies of care. Good communication and regular team meetings are important. The cautionary tale is around finances, I think. Running a clinic is expensive. Care providers have to be committed to seeing enough patients to generate enough revenue to support the clinic. Right now, billing fee for service is still the best way to do this in my experience," Tracy. So I just wanted to share that. Yeah, thank you.
Great. That's a great overview, Christine. Thanks for getting us started. My second question is for Gray. So Gray, the community health center where you work has been on a fee-for-service model, and as I understood from you, is currently sort of making that shift over to salaried physicians using the Ministry of Health PCN model. Can you tell us a bit about that model and help us to understand the implications of transition for your team?
Sure. So Island Sexual Health has been around for 30 plus years using a fee-for-service model and providing sexual health only services, and had a group probably, kind of 20 physicians or so sharing probably 2 to 4 FTE. So not, there were a few kind of core physicians providing 2 to 3 days worth of service, and then lots of other doctors filling in here and there. And then in typical, they were doing a split in terms of the fee-for-service billing for the physicians in the community health center. The model really over time had become less sustainable. They just weren't generating the amount of billing that was necessary to run the operations. And so partly in response to that, and partly in response to also wanting to be able to provide more care for people. So lots of people coming in that had primary healthcare needs that weren't attached, and them not being able to attach them or even find anywhere to attach them. Victoria has about 90,000 people unattached, 80 to 90,000, huge unattachment problem here. So they submitted a proposal to the Ministry of Health to be funded through the Ministry of Health. And so switching over the physicians from fee-for-service to contracts, and then adding in additional team members, RNs, nurse practitioners, a counselor. So that proposal was approved earlier this year, and we're in the process now of making that switch. I think that, there's lots of implications, but, for the physicians in particular that have been working there for some time, they will continue to work there. So they're going to move from that fee-for-service split over to being on contract. The contracts are signed with the community health center, not with the health authority. And we're developing those contracts in consultation with the health authority, really reflect the nature of the practice. And so I think, some of the implications now is there's more income security for the physicians. They don't have to worry about the fee-for-service billing. They know what their earnings are going to be. There's now a team kind of wrapped around them as well to support them. Obviously different from your situation in terms of these aren't doctors that were working independently and then moving their practices into a setting. They've already been working in that community health center setting, and so are used to being part of that team and kind of working with that shared philosophy of care of the organization. I think, we've done lots of physician engagement with the group. Overall, people are very excited about the move. I think they're excited about the increased support, the team-based care. They're, excited to have income security. And so it's been quite positive, the transition. There are, concerns about, moving over into that contract and what that means in terms of responsibility of the health authority and the Ministry of Health. And, but I think overall, it's been quite positive and really, it's been well received.
Great, thanks, Greg. So that's 2 quite different models that we've heard from. Laura, let's hear from you. It'd be interesting just to hear a little bit more about how Sun Peaks Community Health Center is structured in terms of the sort of the business plan and the governance aspect.
Well, our story is a little bit unique. Can you hear me okay? Yeah. Our story starts about 20 years ago when before actually Sun Peaks was a municipality. We're quite a new municipality. They have 20 years of fundraising behind them. So they raised a great deal of money in the community between the municipality and community members. They struck the Sun Peaks Health Association with the vision of opening this primary care and urgent care center. So Sun Peaks was built and we opened our doors in December 2017. But to echo in on Christine and Gray's points, despite the recruitment of great family doctors and having a seasonal weekend call network, the current fee-for-service business model doesn't cover the costs and presents much more serious long-term financial challenges around viability, recruitment and retention. So those are all common themes, I'm sure. So in order to address these challenges, we work collaboratively with the municipality, to pursue additional and alternative funding avenues to support the long-term sustainability of our operations. The municipality here currently own and operate the center, and they provide support to us in kind for administrative supports, human resources management, and risk management services. They are a great partner. We just simply wouldn't be able to survive up here in a remote rural area without them. The municipality approves the annual budget and authorizes sort of expenditures, that sort of thing. Our leadership structure really comes from both organizations. The authority, the board of directors, is the decision-making entity from the Sun Peaks Health Association, and the municipal council is the decision authority on the municipality side. The directors are responsible for the administration and the management of the Sun Peaks Health Association business, and of course they delegate some of that to me. Decisions are made by consensus, and policies and guidelines are established on a joint platform to guide operational decisions, really. The municipality has authority for decision making on all funds within the approved annual budget, and the Health Association Board, the not-for-profits, have authority for decision making on charitable donations, which we do receive, or monies raised from proposals for the centre. I would say that on top of that, some of the benefits of having those community partners have sort of landed us in the middle between what we can do with fee-for-service, because both of our physicians and a third to come on will actually be on a salary, which is supported by the municipality. So we're sort of in that gray zone. We are still working on fee-for-service, but our physicians have a salary, so therefore we've removed some of that pressure from them. And I think, you'll hear from my husband, but I think it does open up the way for better team-based care, and it allows us to meet the needs of the community in a way that, pure fee-for-service is all about volume. And I think, as we move forward to different funding models, we've sort of landed right in the middle, having a great partner in a municipality.
Great, thanks, Laura. That's, as you said, it's kind of a bit of a combination of these different models, so super interesting. I wasn't aware that the municipality was such a partner, so that's really interesting for me. I'd like to call on Chip. Is he still with us? I didn't see him on video, but it would be great, Chip, if you're there, if you could switch on your video. It'd be great to hear from you, the physician on our panel. You've worked in several different settings, but if you could share kind of a physician's perspective, your perspective on the business and governance model of the Sun Peaks Community Health Center and what you see as sort of the opportunities and challenges with that. And if we have lost him. That would be a shame. But if that's the case, we will dive in and hopefully he can come back. But in the meantime, we'll go ahead with our other questions for the panelists that we do have here. So I wanted to kind of dive in a little bit more and see if we could drill down a little bit more in terms of some of these perspectives. So maybe we can start by kind of looking at the governance piece and boards. What do you see in terms of sort of both structuring and training a board as that component of governance to be able to really guide and support a community health center rather than kind of feel like it's hindering it with bureaucracy? Hearing from you, your boards have a little bit different roles in the different settings that you're in. So if you could each speak to that a little bit, that would be great. Just the structuring, training, and kind of role of the board.
So maybe I'll start.
Go for it, Christine.
Sounds good. We have really, really appreciated, especially with our startup, having a lawyer, an accountant, family physicians who have been in private practice, who have also worked in teams. Those have all been really critical in developing contracts and really navigating, understanding roles, responsibilities, and clarity. Having our Indigenous and cultural representative has been really instrumental in how we do our work, and that's been really, really important to us. And so that composition, those expertise, particularly together with a startup, has been really, really great for us. As we kind of move forward, we have our respiratory therapist who's just joined our board, and that's kind of been the composition of ours, and it has brought a lot of strength, and especially around the business startup pieces, that has been really helpful. I'll pass it on.
So for the two community health centers where I've worked, the boards they're not-for-profit societies, and the boards are, I think, probably kind of typical of that. Those are, tend to be professionals for the most part that have an interest in supporting community ventures, and then, possibly a mix of consumers of services as well. And I think in terms of the training, generally the boards that I've dealt with, people often come with experience. They've been on boards in other places, and then as newer board members come on, there's generally some kind of orientation process and some mentorship that goes on around that. Having that mix of skills, as Christine said, is really important, I think, to have those different lenses around risk and business, but also the patient voice and kind of the community needs. Both the boards that I've dealt with are very much governance boards. So they set the mission and the values of the organization. They're responsible for mitigating risk and making sure finances of the organization are in order, and any other types of kind of perceived risks to the organization. But they're not involved kind of in any way, shape, or form with the actual operations. They have a CEO or executive director that they hire, who's their sole report, and that is who's responsible for the operations. And so in both my experiences, the boards are very much hands-off. They provide governance. They might do some fundraising, some community relations, provide letters of support, those types of things. But really the biggest is kind of setting that overall vision and then making sure that there's no risk to the organization and that financially things are in order.
Okay, great. Thanks, Gray. Now, Laura, your board, it sounds like, was structured a little bit differently. So you talked about that a little bit, but help us kind of place that in relation to what Christine and Gray have been sharing.
Well, I think in terms of our board, everybody on our board is knee deep in our community. They're knowledgeable. They're knowledgeable about business, about health systems, the reform that's going on. They have historical knowledge of the area. We have a lawyer, we have a doctor, we have somebody who's involved in the last 20 years of fundraising, who's also on the municipal council. So, having people on your board who are very tapped into, different avenues has been extraordinary. They've all got specific knowledge, expertise, governance, strategy, knowledge. And I'm just going to give this. I'm surprised that Christine, my good friend, didn't mention this book. But this book is pretty life-changing. It's the governance group, Governing Effectively. So this is a bit of a lifesaver. So I would say anybody who wants to know anything about this is like your new best friend. I can send you the details.
Thanks, Laura. We would definitely look for that. Dr. Bantock, we'd like to come to you. So you're the lone physician on the panel. We really appreciate your being with us here. You're bringing a specific perspective that's very important. I see you've worked in several different settings. It'd be great to hear from you if you could share a physician's perspective on sort of the business and governance model of the Sun Peaks Community Health Center and how that impacts you kind of operationally on a day-to-day basis in terms of your clinical work.
Thank you. Yeah, sorry, I disappeared. I got kicked off my own internet for a while. Never happened to me before. So I'm not sure what my wife's already said, so I'll have to tread carefully. Anyway, from my point of view, I've worked a fee-for-service model for almost all my career from Ashcroft into Kamloops. And now I work 2 days a week in the CHC at Sun Peaks on a salary base, based out of, funded by the municipality. For me, first thing I like about CHC is very start of that team-based care with having a nurse there, with having a mental health worker there. And again, I think Dr. Smiley mentioned it in her email to Christine, of having the right team of physicians as well that get along and can work together. For me, from a financial point of view and being paid, as Gray already said, some of their physicians are much happier with getting that funding guaranteed model. And it's quite important in some peaks because we go through peaks and troughs of fee-for-service peaks and non-fee-for-service peaks, depending on the weather and the time of the year. And there's shoulder seasons and things like that. So that's very helpful to have the backing of that funding. I think, though, that you also need physicians, and we see this variably, who are prepared to put the work in as well, because I've always been a little bit of a skeptic about pure salary models, because you can choose not to work very hard, and I think that to support your CHC, particularly when funding is in our situation is being backed by MSP, the top up is through the municipality. You still need to see your patients to try and cover that funding as much as possible, and find other ways of helping that funding model until a better CHC funding model comes out. But from my point of view, it is a bit more relaxing time and part of my career, as opposed to the other 3 days a week when I'm fee-for-service working in my private office, trying to make overhead and cover all the costs. So it is very different that way. I don't have the team support in my office, although I did have a nurse at one time that I covered on a fee-for-service model. But it's a difficult business structure trying to do that yourself. When you're in CHC and you have a manager and a board to support you, you feel you can just get on with your job, which is medicine. And I think a lot of physicians feel that way. So the supported model of CHC, from having worked in both, is a much more relaxing model to some degree from a business governance point of view.
Thanks, Chip. That's really, really helpful. I have a couple more questions for our panelists, but I would urge all of our participants to please, if you have questions, type them into the Q&A box, and we'll try and use those as a guide for questions as we move forward. So please type in some questions. So my next question is really kind of for all of you, is how can these different models, business models, help or hinder a team-based care approach? Some of you touched on this a little bit, but if you could just highlight a bit more from your kind of practical experience. Christine, I see you're unmuted. I'll let you tackle that one first.
Sure. Well, so steps and Orchards Walk are kind of interesting. So we do operate, the majority of our funding comes through fee-for-service MSP, but we do have a base rate of pay, one physician on base rate of pay, because she does care for LGBTQ2+ and transgender care, and the fee codes don't support the work that she does. So we access grants and funding to be able to pay her on a base rate of pay for the work she does. With her, we also have an RN who we get grant funding to pay for her wages. And then we also have some money to pay for some free counseling for that population. And we just got some more funding to have a social worker join us as well. So grant funding does enable that team to do the teamwork that they need. So there's a lot of teamwork that goes into providing care for that population that the fee-for-service model doesn't support. So we do that, and we do supplement that. Then we also have physicians who choose to do fee-for-service. And like Dr. Smiley was saying, she's quite comfortable doing that and wants to continue doing that. I think it really depends on the population that you're serving and where, and you need to take a look at your own personal environment of whether fee-for-service is the preference and it works. Because I also think it depends on the personality of the providers and the team as well, how they go about interacting as a team. So we have a diabetic educator, a respiratory therapist, and a dietitian who are health authority employees who work with us at Orchards Walk. And our providers have become quite close as a team with them, even though they are employees of the health authority. And they work quite closely together with referring back and forth and shared care. So I think it really depends on personalities and desire and what somebody's looking for. Fee-for-service can, I think, work with the people who want to do that, but there's some work and some populations that just can't be cared for adequately because of the fee-for-service model. So I'm happy to answer any questions around that too.
Oh, that's really helpful. And it's interesting to hear how you have the fee-for-service model, but then you're also working with the health authority employees as part of that team, and then the grants and funding stream. So it's really kind of a mixed model.
We also have a nurse practitioner, I should just add too, that is an employee of the health authority. And we have a contract with the health authority, and she works at Orchards Walk as part of our team.
So we've described it as fee-for-service, but it sounds like it's actually a little bit more of a hybrid.
Well, it's fee-for-service. That's where we get all the majority of our funding. And then we have STEPS employees, we have contractors who are physicians, and then we also have health authority employees all working together.
Okay, that's great. That helps me to understand it better. Great. Let's hear from you in terms of the team-based care and how that your business model kind of supports that, and what are some of the challenges there?
So I think in the models that I've worked in, so all of the allied health and administrative staff are employees of the community health center, and then the primary care providers, be they physicians or nurse practitioners, are on service agreements to provide services to the community health center. So that's the business model. In those, you kind of have a master agreement with the health authority and the Ministry of Health that says you're going to deliver, X amount of services to X amount of people. But then within that, you're able to kind of carve out how you deliver the care. And so that enables you to really actively manage the team, to have paid professional development, to have regular meetings between your providers that are paid. And so I think it really does a great job of creating that flexibility to allow the team to really work together. And not to say that in the fee-for-service model, teams aren't working together, but I know, when you're able to have it structured and have it be part of the compensation, and not be worried about missing out on billings and different things like that, it really does help out. And I wanted to make a little bit of a comment about what Chip said about having, doctors that kind of are committed to it and pulling their weight. And I absolutely agree with that. I think in the service agreements, usually there is some active management of the team. And I think, if you do have team members that aren't working well as part of the team, then they don't always stay on, and the organizations have some, they have responsibilities and rights that they're able to end those contracts as well, because you do want everyone working together. But yeah, I personally believe the contract and salary environment really does support team-based care, and it allows people to work to scope. At Island Sexual Health, in the fee-for-service model that we're leaving, physicians were doing a lot of work that really is in scope of the RNs, because they need that volume for the fee-for-service billings. And as we move into the contract area, they're able to provide kind of more specialized care and work in areas of interest that maybe don't have the same billing rates, but might be of more interest and more value to patients. And then some of those kind of lower skilled jobs like injections and different things like that are then tasked out to RNs and other people in their scope.
Very helpful, Gray. Thank you very much. So we'd like to turn this to you, Dr. Bantock and Laura, just to hear kind of the team-based care approach, and how does that work in Sun Peaks? And I'm not sure which one of you wants to tackle that first, or from your respective perspectives.
I think I better speak first, don't you, Chip? So I think that having a sort of a team philosophy and really concentrating on collaboration and being really open to everybody's input is what can save this situation. I think it hasn't happened here, and I'll go on to explain that, but I think we do fear having different compensation models that might cause challenges. I've certainly thought about it. I think having a medical director like we have here, plus a really strong community board, helps us navigate, through any of those challenges. I think everybody has to have a willingness, all of the personalities involved, to really concentrate on collaboration and problem solving, and being open to have every single person's opinion on the direction that we take. And I think that creates the investment piece and the value for all the team members. For instance, we have two mental health workers. Mental health is quite a large slice of our pie here, and we have one who is paid by the health authority and one who's a private practice. But when we agreed to sort of incorporate them into our community health center, we did sit down and say, we do team-based care here, and we value everybody equally, and this is going to be an even playing field. And we absolutely had zero problems taking that approach and making sure every personality shared the same philosophy about team-based care that we did. So I think collaboration is sort of the word that I would emphasize anybody trying to sort of mix models. Ideally, what I would like to see is one sort of compensation model. I think would be easy, but it hasn't been a problem thus far.
I think my comments with regard to that is we are not a health authority site at all, and then really have very little connection with the health authority apart from mental health. They seem to operate a little bit on their own in our health authority compared to the other community parts of health. So we were very lucky to grab that piece. I think private mental health worker has been a great step, and I've never had such good communication with mental health since those two people have been there. I think that the problem with our model is if you get the nurse practitioner, for example, who could do some, or another full-time nurse doing some of the work that Gray suggested, it's a great idea.
We're losing you a little bit there, Chip. I think you're a little bit frozen. As are you, Laura.
I turned myself off. I was just going to say to Chip, he should turn his camera off and just speak. I can't pretend to talk for him, I'm afraid. But I feel like I should text him. Now you're on mute.
We'll come back to you, Dr. Bantock, because I think it was a really important point. I really appreciate just the mention of the connection with mental health, and we would love to hear more from you about the issues in terms of the practitioners being able to work to the scope of their practice. I will move on for now to sort of one last question from me before we turn to the Q&A box. So just urge again, everybody who's a participant, do please put your questions into the Q&A, and we'll come back to that. So I did want to just kind of build a little bit on what Dr. Bantock was saying, and I'd like to hear a little bit more about sort of the community services and private services that could or should be co-located and even integrated with a community health center. And I know this is kind of done differently in different places, but we'd just like to hear from you about how business or governance models have helped you to really bring in those outside services, either community services or specific private services. Do you want to tackle that, Christine?
Sure, I'll start. I think the business model that you choose is going to be an enabler. So things like a not-for-profit vehicle, for instance, what you can do is you can apply for charitable status, you can go after grants, you can go after different funding sources available. So I think that that's one piece. I think, you know, kind of going back to what Gray and Dr. Bantock and Laura have said, ideally, you know, everybody would be employed by the same person. Everybody would be under the same strategic plan, governance structure. That would be ideal. I think that there's ways of making it happen if you have a collaborative team without, you know, if you don't have that luxury. We didn't have that luxury. That's why we're on the fee for service with employees, contractors, and employees of other organizations. I think, yeah, I hope that answers some of the question. Maybe I'll pass it on.
Gray, what about from your perspective?
I mean, I think you know, obviously your physical space and access to it, I mean, sets up all kinds of opportunities. And I know that many of the association members, community health centers around the province are kind of hybrid models like Christine, where they own the building or, and then they may employ some of the services within them, but then they're co-locating, leasing space to different allied health. And then there's kind of different degrees of integration. Again, not-for-profit status is really important. I think, you know, there's also the opportunity for social enterprise within that. You can have, there are a couple CHCs that have pharmacies embedded within them. And then any of the revenue from that pharmacy contributes directly to supporting the operations. I think, you know, dental services, we're not talking about that necessarily today, but we know that's a huge, you know, access to low-cost dentistry is a big thing. And several community health centers in the province have that as part of their model. And that might be something for you to look at. I mean, I know it's a big thing to choose off, but I think there's lots of opportunities to co-locate, to provide rental or lease space to types of services that are affiliated with what you're doing. And then there's also opportunities for social enterprise to have some type of revenue that can be supporting some of your non-funded services as well.
Thanks, Gray. And if we can, Dr. Bantock and Laura, it'd be interesting to hear from you on that in terms of the type of sort of co-location of services or integration with other services.
Well, I think, you know, this is where your community board is really essential. And I think you do have to step back and look at the needs of your community. Like in our situation, we're remote and rural, and, you know, our needs, as I mentioned before, our panel, when I pulled the data, you know, mental health was just a slam dunk. I had to get services here for that large piece of our panel. But right behind it is, you know, could I get Life Labs here as a satellite? You know, because some people literally, you know, it's an hour's drive in the winter to the closest lab, as well as being a resort. You know, fractures are our we need an X-ray. So, you know, I think it really is, it would be, if you have the space and the environment where you can incorporate other pieces, that's going to tell you who should be in your CHC. You know, for us, it's not a creche, but in times of COVID, when everything's very difficult, I did entertain a food bank, you know, these sort of things. I think your community dictates what's important, given location, geographic, service providers, all of these things mashed together.
Can you hear me now?
We can. Dr. Bantock, please dive in.
You're lucky there's no video now. You don't have to look at me. I just echo what Laura said, but I just wanted to go back to some of the funding model there. If you had a nurse seeing, as Gray mentioned, doing some of the lesser work, then we're still in a situation that you can't bill MSP for some of that, and then we don't have the volume up at some peaks to replace that. So even if we got a funded nurse from somewhere else, we then have to take on more patients, which is great in a situation where patients are very available. Now, we're fortunate that people will drive up from Kamloops. As Laura might have mentioned earlier, we've got a number of thousand patients who actually come up from there. But can we still continue on those resources? So you do have to pick, your support people carefully, depending on the funding model that we're running at. And that's why I think Laura's mentioned the more global funding model, where you can put money where the needs are, would in the long run be far better. As far as supportive care, mental health, other x-rays, I agree. There's so many other things. We're very different and unique as far as being a holidaying community most of the time.
That's helpful in terms of helping us to think through how to structure those sort of payment models and business model in order to really meet the needs of the actual community and the structure of the community in terms of who's there, and whether you're trying to cover unattached patients or trying to make sure that you're bringing in enough fee for service. So I think that's an important point. I wanted to sort of follow up on that with a question from Andrew, who said, as citizens, we really want all these different models to work locally, but also for all of BC. And we're obviously looking for a combination of quality and efficiency in terms of the cost of care per patient of primary care. So when we look at a potential move to salary of physicians, which has very much a reputation of high quality, but sometimes of mixed efficiency. How can we gain the quality, but without losing the efficiency? So it'd be interesting to hear from you, specifically around what's the role of local boards and administrators in helping to make sure that we have both the quality, but also maintain the efficiency. Who would like to tackle that one? It's a bit of a big one.
I'll tackle it, because
go for it.
Andrew knows what I'm like about these things. I mean, let's take health authorities out of the picture. I mean, get better funding models and get boards to run these CHCs, and I think you can save a lot of money and be a lot more efficient. I know that's controversial, but I've been fairly outspoken about that in the past anyway, at different levels. You know, I do think that a lot of these boards are well chosen, and if you choose your right administrators, I think a huge amount of efficiencies can be made. And I really wish the government would look at this much more closely. I think the way that PCNs are going and the costs of health authorities being involved and bringing health authority employees into the picture may be very necessary in some situations, but it's not cheap. I think there's other ways of doing this, but I'm getting a bit political.
Okay, thanks, Dr. Bantock. Gray looks like he's ready to respond and share another perspective.
I have so much to say on this. I mean, I think, you know, how efficiency in terms of overall cost to the system, to the taxpayer, right? I mean, I think it is one of the way I look at it. And so how do we measure healthcare? Is it it's the overall cost of providing of a person to the system. And so the community health center model may not see as many patients per hour, for example, but there's lots of studies that show that community health centers are very effective in comparison to other models in reducing ER utilization. When people do go to hospital, they're going for shorter times. They're addressing the social determinants of health. So they're attaching people to housing, food security, income entitlements, and things like that. So they're attaching people to social services in all kinds of ways that support lower costs to the overall system. And they're also reducing costs in terms of inappropriate ER utilization. Community health centers have extended hours. They have different ways of creating access so that people are coming to the community health center rather than going to the ER. And I think also, in a community health center model, so for example, say you're saying 3 patients an hour versus 6, maybe in a fee for service, if you're counting it based on what's being done in each visit versus how many visits, you'll find that they match up. So at Kool-Aid, we counted this a lot. So someone might come in for a 20-minute visit, but on average, they were having 2.4 issues addressed in that 20-minute visit. And we were shadow billing all of those. So our MSP billing, even though the visits were longer, the overall amount of work that was being done looked very similar to a fee-for-service practice. And then I think the other part is the right provider seeing the person for the right condition at the right time. So at Kool-Aid, again, 50% of our visits were not with a physician. They were with an allied healthcare provider, a nurse, dietitian, physiotherapist, all of whom are making less money than a physician. And so, instead of having a person that's making $150 an hour seeing somebody, you're having a healthcare provider that's making $37 or $40 an hour for something that's well within their scope: diabetic counseling, lower back pain, wound management, all of those types of things. So I think there's all kinds of ways that community health centers create efficiency. Obviously, it's up to the administration and the board to ensure that those metrics are being collected and looked at on a regular basis. And in that case, I'm a firm believer that they are very efficient and cost effective when you look globally at what services they're providing.
Thanks, Gray. Christine, did you want to tackle this also as a kind of a hands-on administrator?
I think Gray hit the nail on the head. So thank you, Gray.
I can jump in. Is that
absolutely, Laura? Let's hear from you.
Is that good?
Yes, please.
I think that it goes down to this idea of a shared philosophy for team-based care. I think if you can choose the right people to be part of your team, that goes an awfully long way. I also totally agree with Gray, the use of allied health. We have my husband and I, we did employ an RN in practice. There was a massive increase in the patient experience was vastly improved. Diabetic screening, teaching, across the board. She was fantastic. She did a lot of, things that you just don't have time to do on a fee-for-service model. So I think the quality care, is definitely where the community health center can really step up the experience and the outcomes for patients. And I think keeping people where they live, keeping people out of the emergency department, increasing access, we really do abide by what we say. We want to see our patients. We don't want you driving to Kamloops to sit in the ER. If we can suture you or, do this or that or whatever you need to have done and keep you here, we stop the ambulance, we stop the 6-hour wait and emerge. I could go on and on and on. But I think use of allied healthcare, and really it all just goes back to that team-based care approach. With it, and actually to go back to my training in the UK, it's patient-focused care, which I think is what we all aspire to.
The next one kind of builds on this, but is actually from a village councillor in Cusp. And just looking at the ability to attract medical staff. So they were specifically looking, is there kind of a space within community care for somebody like a lab tech? But in general, how could a community health center help to attract medical staff? And just for those of you who aren't familiar, NACUSP is we're definitely sort of rural and remote. And as Susan said, has sometimes struggling to attract and retain medical staff. So if you could speak to that, the recruitment and retention, and how being a community health center has helped or hindered that.
I can speak to that just briefly, and I've got to go shortly because my office starts in 5 minutes. But this is, we had this conversation at the division level with Sun Peaks before Laura started this off. I mean, the biggest problem with recruitment up there was that they really had this dream that some physician would work up there and build an office and survive off 650 patients a year, which was totally unrealistic. So the community up there did listen to divisions and a number of physicians to start this situation off, of which funding was an important part. I mean, a lot of volunteers, a lot of money put aside to build the community health centre, which of course is probably 3 or 4 times bigger than it requires to be if you were actually a private practitioner trying to run a practice. So the costs are huge, but to have the guaranteed income, to have it was probably a huge start, because anyone fresh out of residency is not going to take that risk from a private practice point of view. So having that community support in that municipality was hugely attractive. And we really, Laura managed to recruit 1 doctor full-time, and then obviously recruited me. But then we've also had weekend coverage and support during the ski season, which has been phenomenal, and never a problem in recruitment. But that support from the community has been great. I mean, even at the weekends when we have, the community has provided a place to stay for those physicians. Not for regular physicians, but for those ones who are coming in to cover urgent care at the weekends. So those are the sort of things a community can do to recruit and help people join the service.
Thanks, Dr. Bantock. If you have to slip away, we totally understand. It's been great, really great having you and your perspective as part of the webinar. So we'll hope you can stay with us as long as you can. And when you do have to go off and do the other part of your job, please do so. I had a couple of practical questions that have come up. One was, where do you find grant funding for the specialized care? So I think this speaks to a bit the issue of being structured as a CHC, and thus, the structure as a nonprofit and the ability to get grant funding. So Christine, if maybe you could speak to that, and if any of the rest of you would like to weigh in terms of just some of the grants that you've been looking for and some of those other funding streams that have helped you to provide a full range of services, that would be great.
Yeah, so foundations, like charitable foundations, often they have, especially community foundations, often have funding available for innovative solutions to even education. There's government grants that come up quite regularly. I think there's an infrastructure one right now. I would say that those are the main ones. And if you get charitable status, it's easier to access those. If you're looking at a member-based not-for-profit, that might be a way of generating income to provide support for your governance. You'd have to figure out who your members are, and we have the ability to do that in our bylaws, have members, but we haven't gone down that path yet. But I hope that answers your question there. That's a few of where we find our grant funding. Gray's really good at grant writing.
That's great. Gray, do you want to comment on from your perspective?
Yeah, I mean, when I was at Kool-Aid, I would say that was a significant portion of my job. So foundations, BC Gaming is a great source. United Way is another good source. If you're looking at federal grants, they tend to be administratively heavy, but they tend to have larger amounts attached to them. So PHAC, Public Health Agency of Canada, is another one. There's the Community Action Fund here in BC around mental health that was released as part of the opiate response. So there are many, many grants available. It does take some work, and they are time limited. but they're certainly out there. I would add into this, and this is a more controversial one, and people may have different feelings about this. When I was at Kool-Aid, we did a lot of work around hepatitis C and HIV, and there are many pharmaceutical companies that are willing to support that work with project grants and different things like that. I know people have different feelings about that. I always found them, decent to work with, and certainly weren't encroaching on our practice, but they would pay for things like a nurse to go out and do testing in the community for Hep C and treat people off-site. We got some funding to run a stimulant use disorder support group as well. Like we got pharmaceutical industry funding for a variety of things that were quite beneficial for us.
Great, those are some really interesting sources. Laura, did you have anything on that to add?
I just had, yes, there are foundations. We get a lot of community donations, and we also, of course, have, the ski races, and we're often a benefactor from those. But grant writing is an art form, in my opinion. So, it's kind of my very least favorite job. But I did just want to mention, just so that it might be interesting to some. The other, just circling back to what my husband was saying, we are actually a UBC training site. So we have residents, we have, 2 R1s, 2 R2s, and then both of our doctors here are educators. So, we've engineered exposure to our CHC through teaching and education. So that's an important piece for recruitment and retention. I joke it's like Hotel California, right? You can never leave.
And they provide revenue. Medical students and residents, there's compensation provided, I'm sure, as the physicians are aware. And in a community health center model, you may choose to have the community health center hold those earnings and then contribute toward the overall operations. Things like staff development and types of those, it's a good way to fund them as well. And they're not insignificant. You can generate a fair amount of revenue through learning opportunities.
Yeah, I just want to add that we train 4th year BSN students, 3rd year BSN students, nurse practitioner students, medical students, and residents as well. So exposure, if you want to recruit, colleagues recruit colleagues. We've just had 4 family doctors start in the last 2 months.
And both community health centers that I've worked at, we have wait lists for physicians. We turn people away.
Yeah, I agree. Once they see what it's like to work in this sort of environment, they really like it.
So you've covered both all the various streams of revenue and also retention and recruitment. We're kind of moving into the final phase of our webinar. We just have a little bit less than about 10 minutes left. I want to just turn a bit back to the sort of board management. And Andrew had a couple of interesting questions around that in terms of what are the sort of most important roles or sort of benefits contributions of community and patient board members. So those who are kind of bringing that patient perspective to a community health center. What gaps are they filling? And kind of overall, what does it take to make sitting on the community health center board a positive experience for those members, where they can really feel that they are contributing in a really useful way and that their inputs are sort of being incorporated? So if you guys could speak to that a little bit, I think that would be really interesting. Did you want to go ahead with that, Christine?
Sure. We haven't done a ton of patient interaction yet, but we are just in the process of implementing Health Myself portal, and for all of our providers, including our RN, possibly our social worker, and we are looking to push out surveys and interact that way. Board of directors, if you have like-minded, collaborative, if you're recruiting team players and you're recruiting a team for your board directors, your directors of your society are responsible for everything. They are on the hook. They're it. They're where the buck stops. So insurance is really important. Just tossing that out there. And And I think you want to be recruiting team players who understand their responsibility as a director, but also their responsibility in supporting patient care, supporting the patient-provider relationship, because you certainly don't want a hierarchical, authoritative, weird structure or personalities, because it will slow things down. You want innovators, you want people who have lots of energy, you want problem solvers, you want kind people, I would say, and who can get through stuff quickly. That would be my 2 cents on that. Laura and Greg probably have lots to say.
Thanks, Christine.
No, I think you nailed it, Christine, except for I think it does help if you have people on your board who understand a bit about healthcare from a systems point of view. I think I think that's I find that very, very helpful. But other than that, Christine said it very eloquently.
And Gray, from your perspective.
I think in terms of, having community members or patients on your board, I think they provide, and I agree with everything that Christine said. And then I think just in addition to that, they provide a bit of an outside perspective and kind of, they might have the pulse of the community and how your services are perceived or how patients and community members are responding to your services. So they bring that lens to the operations, which, as providers, you don't necessarily always get because people aren't, when you're the doctor, you may not get the unfiltered. I mean, you do in some cases, but sometimes, people are respectful of that relationship. So they can provide that conduit for the vibe of the community, and patients in particular can tell you about how your services are being perceived and experienced. Yeah.
Okay, great. I think we'll have this one last question and then we'll be wrapping up. So Jan Morton, who's on our board, mentions that securing charitable status can be a really onerous process for any of us who've been involved in that. So I think just be interested to hear from you in terms of how you handled just the application for charitable status. How did you get that charitable status? And did you outsource that to lawyers? Did you do it yourselves? And if there's any sort of policies and procedures that you could share with us that helped you. Who would like to tackle that one?
Well, maybe can you hear the buzzing in the background, or is that okay? Okay. So we do not have charitable status yet. And it's an ongoing conversation. What we have found is so far we don't need it, but we've also found a charitable society with purpose statements that are in line with our delivery of care and what we do. So they have, in partnership with them, they have applied and received funding, and in partnership, we're a contractor in delivering those services. So it really depends on what you have for societies and other purposes within your community. You might already have access to other organizations who can hold those funds and contract you to provide services depending on what you're going for. We continue to look at the charitable status, but we haven't done it yet because of the financial reporting and the application, and we're not quite sure if we need to do that. We found other avenues to be able to deliver on what we need to deliver with the organizations in our area. So.
Great. Did you have another perspective on that? You're muted.
I've never had to go through the process. All the organizations I've worked for have already had it in place when I've started there. So I do know I am working with another group that's a group of doctors locally that are forming a community health center, and they're taking the route of working with an existing organization that already has charitable status and kind of merging with them under their governance model to form their community health center as kind of a simpler route to go to that.
Thanks. And Laura, did you have anything to add? I know you are, again, kind of structured differently. yet differently
Yeah,
again.
so ours is a little bit interesting. Our not-for-profit status, the Sun Peaks Health Association, has had it for years, 17, 18 years or something. So I was not part of. I've worked in the not-for-profit arena for a long time. I do know that it is challenging to set up from scratch for all the various reasons. But also, interestingly, a municipality is by its sort of nature a not-for-profit as well. So I'm not quite sure about the communities that are tuned in, but you know, as Chris says, there are definite pros and cons to being both, but yeah, that's about all I can say. I'm glad I have it.
Okay, well, we're just coming up to time. So we're gonna be putting up a brief evaluation, and we would really invite all participants and panelists, you're welcome also, to provide some feedback to us that will really help us to both make these webinars better and learn from our experience, but also kind of the ongoing and bigger picture process of trying to explore how to look at the future of clinics. So we really appreciate all of the feedback that you can give us. I'd like to give a huge, huge thanks to our panelists, Christine, Gray, Laura, and Dr. Bantock. Really great to get your range of different perspectives and experiences. So thank you so much for sharing that with us. And I think you can count on us to come back to you and ask more questions and ask you to share more documents with us. It's extremely helpful, and I think it helps us to really understand what are the range of possibilities and some of the details that we need to think through. We will probably have more webinars. I think we'll take a break over the summer because everybody's ready for a rest, and it's hard to pull everybody together in August. But we're looking to have at least one more webinar in September, kind of September, October, and possibly more. So if there's specific issues that you would like to delve into in more detail, please let us know, and we'll try to structure a webinar around that. So thanks again to all our panelists, and huge thanks to all our participants for opting to have your lunch hour with us as opposed to a more relaxing break. We really appreciate your participating and your questions and your engagement. And please fill out the evaluation before you go, as that really helps us.
That's a pleasure. I'll sign off just with one more message, that if anybody wants to pick up the telephone or they want to drive up to Sun Peaks, very happy to show people around or have further discussions.
That's great. Thank you so much, Laura. I know we'll be following up with you for sure, and I'm sure many others will be too. Any final comments from Christine or Gray? If you'd like to share, please do.
SEPS is happy to host anybody as well, and feel free. Call or email anytime. We're happy to answer questions, and if any of the physicians want to speak directly to a physician, I'm sure our physicians would be open to answering any questions. We really are interested, our board is interested in sustainable community health center models and supporting anybody and populations and communities in meeting the needs of their people. So please reach out if we can help at all.
Okay, so I think we'll sign off now. But thanks again, everybody.